illusion. It is not a hallucination. We are actually back after a very long layoff. And I actually have the entire group here today. So I've got Terry, Christine, Paul, Scott, and Stephanie. So welcome back to the program, everybody. And to all of you who are tuning in, logging on, and hanging out with us, welcome. Whether you're watching us on Riverside, which is our Compliance Guy studio, or you're on LinkedIn or YouTube or X or Facebook, welcome. We're excited to be here. I think we have a very good conversation today because we have three topics that I want to get to, and I'm going to save our skin substitutes for a little bit later on. I think let's start with a universal problem, and that is the use of students in medical practices whereby providers believe they can leave their practice because they have a student in the office, uh, leaving them to either uh, evaluate the patient, diagnose the patient, or treat the patient. And this is something that I am getting some interesting phone calls about in not just behavioral health, but in a multitude of specialties. And I know Christine, Terry, Paul, Scott, Stephanie, you all have had experience talking to clients, engaging with other healthcare professionals where this issue has surfaced. So, who wants to jump on this one first?
I'll take it first.
Okay.
Now, one thing that, we have to reiterate, like Sean was saying, regardless of specialty, remember, students cannot perform or do any work that is billable and reimbursable. So that's going to become really problematic once. Okay, there we go. We had some feedback. Um, I always think to the time where I had taken my daughter to a local ER here, and she had a laceration and needed a repair done. And as I'm sitting there in a hallway with her repair being done, I'm looking around and read the badge of the quote unquote provider that says he's a student. And I bring up the student as he's, repairing, and I bring it up and he's like, "Oh yeah, I haven't graduated yet. It's coming up, at such and such a time." Physician's nowhere to be seen. Hospital then charges me tons of money. We were self-pay at the time. I try to get a hold of their compliance department, their coding department. Nobody's listening to me that that person couldn't have been doing it. And if the note said the physician was there, it wasn't accurate. So, they can't perform anything that is going to be billed like that. All they can do is the documentation, and then we can look at the re-performance from that physician standpoint. But one of the big areas that I know we see this in is behavioral health. And for myself, I've seen this as a large disconnect either on the student side, or I have a little more experience on the graduate side where the individuals have completed their college programs, they've graduated, but the problem is there's a disconnect in the industry where states require them to get basically their clinical hours, but they don't have a GME program. So we're left with this holding period where practices have to really understand the billing rules and look to, Christine, you were saying self-pay programs. I know that I've done that myself personally, even with my daughter getting therapy, just because there's a lack of care. So a lot of practitioners look at bringing in the graduates to fill that void, but they're not billable services to the payers. And I will say there's a caveat where I have seen some payers, occasionally a blue will allow it, but it's been very specific state to state. And there's a written policy that black and white states they allow a graduate and tell you how to bill for it from there. But overall, this is not something that can be done on a large scale. And, I see it being implemented in practices across the board, not looking at payer, not looking at student versus graduate, and, all of these variables that come into play.
And you're right. I think that's one of the biggest problems that we run into is individuals um, being ill-informed or uninformed with respect to the guidelines. And these are not universal guidelines, to Stephanie's point, because you may have a Blue Cross Blue Shield who provides guidance to say, we'll allow a graduate student to provide these services under the direct supervision of a licensed therapist under these conditions. And the other thing, and I want to make sure I'm getting to everybody on this topic, but there's something else that I also want to throw into this conversation is the transition not only to utilizing these graduate students or using students, but to now allowing AI to create the notes based on some check boxes. And again, I know I'm kind of muddying the waters a little bit, but I'm seeing the use of the AI. And one of the explanations I was given a couple of days ago, meaning last Friday, from a group that I was talking to, they said, look, we have structured our EMR and the AI portion specifically with a number of checkboxes that the student or the graduate could go in and check these boxes, and it will automatically populate documentation in accordance with what our specific carrier is asking for. But here's the problem with that. And Terry, you as an auditor for the government agencies, if you're creating these checkboxes and you click these checkboxes, what's automatically going to happen? It's going to populate the same phrases over and over again for every single patient encounter, which is going to lead to what? Cloning.
Cloning.
Yeah.
It's terrible.
So,
Christine, I know you want to
yeah,
get
go
in here
ahead.
before I get in. Go ahead.
Well, I wanted to unmuddy the water real quick, Sean. So one of the things that we do need to remember when using AI or using anywhere else is, and we're going to talk about this a little bit later, about the practice expense that's included in the CPT code. And that's the word, practice expense. These students are not an expense that to be reimbursed. And those practice expenses, whether it's Medicare or whether it's Humana using the Medicare fee schedule, the fee schedules are built on including those practice expenses. So again, if they're not an expense to your practice, if that is not an expense to your practice, then you're getting paid for something that you're not really entitled to. You didn't really support. So think about it from that perspective, is that we have to remember that anybody's services in the office, whether it's the medical assistant taking the history component, that expense is bundled into the reimbursement. The physician, that expense into the reimbursement. That's why we measure how much data was actually utilized in determining how do we manage this patient, how much, the presentation of the problems, what is that complexity, because it might take more skill, more time, more intensity, more resources, and why we don't use an E&M and a procedure on the same day, because that E&M component is already bundled into that procedure from the practice expense perspective of it. So I just wanted to unmuddy that a little. You can't get paid for something that didn't cost you something, that there's no reimbursement for.
No, that's a
Right.
great point. And Terry, as an auditor for payers, right? One of the things that I know after 30 years of doing this, 30 plus years of you doing this, um, you have a very keen eye on picking up patterns and picking up, as does everybody on here. I mean, that's the reason why you all are part of this panel, is because you're subject matter experts. You all have audited probably more than 1 million claims each during your professional careers. So there's a sense of knowing what to look for, when things to start to become a detectable pattern. So talk a little bit, if you can. I know you had something that you wanted to say first, but
Yeah.
talk about that, and then talk a little bit about these detectable patterns. And then I want to go to Paul and Scott and let you guys kind of chime in, because the amount of audits that we're seeing,
Crazy.
that are tied to the Max, and then the investigations that we're seeing coming from the UPICs and from the SIUs. And Stephanie, you and I had a great conversation with Eric Rubenstein last week. I think it was last Wednesday where we were talking about this. And I want to reemphasize a point after we kind of go around the table. So go ahead, Terry, please.
Well, I think the one thing that, you know, in a payer audit, it's a little different than it shouldn't be, but it's a little different than a practice audit, where when we start to see a pattern or identify a pattern, we all see them. Everybody on this panel has seen it. All of a sudden, you're like, I just saw that phrase, or didn't I just see that when I looked at a data service, 2 weeks ago or whatever? And I know Scott and I have shared a chuckle over seeing stuff like that. I'm like, hey, I'm seeing this like every single visit. And so what we do in payer audits is then you say, okay, well, I'm going to go look back and figure out, did they do this the last visit? Did they do this the other visit? Hospitalists are a big issue right now with this. And so, just seeing that it's just a repeated pattern. And the payers want us to do that. They don't just want us to focus on, the encounter at hand. They're like, look at the entire scope of what's going on here. And I tend to also expand that when I do physician and practice audits, because that's my mindset. I want to make sure I can protect you from yourself and say, look, you may say, well, this visit is independent. It maybe it is, but then what happened last week? What happened yesterday? What happened, a month ago? And it's saying the same thing. And the other thing I want to mention, you mentioned students, and then coming back to the student thing. One thing, and Christine and I have talked about this, and Stephanie and I too, we're not just seeing students being utilized incorrectly, but you have a medical assistant or you have an RN, and they're calling them nurses when they're not nurse practitioners. Or I've seen Dr. Bobby when it's a PA, and they even have it on their name tag, and it makes me cringe. I mean, even in my doctor's office, and I called him out on it. When I knew it was the medical assistant, and I said, hey, I said, her name's not Jackie, so I'll use that name. I said, hey, I see you have Nurse Jackie on there. And she goes, yeah, they just started doing that with everybody. I go, but you're not a nurse, right? And I go, are you even an RN? She goes, no, I'm a medical assistant. I'm like,
But
oh my
see,
gosh.
that's such a great point, Terry,
It's
right?
terrible. They're
Because
not nurse practitioners.
we actually, I don't know if Scott or Stephanie or Paul, it may have been a combination of you guys. You all worked with me on a case last year where an individual was indicted because they were calling themselves Dr. So-and-so, but they were a physician assistant. And this was something that the prosecutors absolutely were relentless on. They went after this because it was a misrepresentation, and not only that, it violated the Deceptive Marketing Practice Act in the
But Sean,
state where this
but the
happened.
other
Go
thing
ahead.
is that patients will walk into a room, and if they think you're a higher level professional, you are a nurse practitioner, you are a PA, you are a physician,
Yeah.
they will share with you information that they feel safe to do so. If they knew that it was a medical assistant, I guess this kind of falls into the marketing kind of, subliminal, the medical assistant, or, and not to discount an RN, but just not somebody that can build independently. I guess that's
Yeah.
the way to look at it. It's really deceiving the patient, because they thought one thing, and then you always know the person who really is the provider comes back in and then asks the questions all over again, and the patient's like, wait a minute, I just told that person and they said that they were your nurse,
Yeah.
but are not. But it's really unfortunate, because bringing it back again to the student thing, I'm finding that in some payer audits, which is really unfortunate. As soon as I see it, I'm like, okay, I need some Tums, because basically they're trying to bill E&M services under RNs,
Yeah.
under medical
that's a
assistants. And
problem.
they're like, yeah, but okay, like I played one on TV, but they've been here for, 10, 15, 20
Yeah.
years. And I'm going to throw it to Scott on this one, because Scott, how many times have you heard what they've been here? They know what they're doing.
And before Scott says something, I just want to say this. Congratulations to Scott. He had his first major deposition in a very big case. We're not going to talk about it, but I will tell you, having the privilege and opportunity to work with Scott doing doing deposition prep, knocked it out of the park. knocked it out of the park. So congratulations. So I just want everybody to be aware of what an outstanding job you did on that. All right, go ahead.
Thank you, Sean. I appreciate that. And I'm not even sure. There's so much going on for me to respond to here, but I think, when you think about like consumer fraud, for example, like if you look at it from a whole different perspective, like if I go to get like my hair cut, like the state licenses this person through some sort of process, right? Instead of a license, it's like consumer fraud. And, I don't know why the same principle wouldn't apply when you're talking about giving medical histories, when you're talking about a representation of a level of expertise that this person does not actually have, right? And so when we're talking about a student, and we can all appreciate, I think, to some extent, we've all been students, right? So when Sean says we've all looked at a million claims, and I was trying to do the math, and I'm not sure it's a million really, because that would be like 50,000 a year for 20 years. Maybe that's the number. At some point, I had only looked at 10 claims. At some point, I had only looked at like 5 claims. And so the expertise that we represent should be something that is sustained or substantiated. And we do that in healthcare through credentials, through licensure, through an enrollment process, through a validation process, so that as a healthcare consumer, I can trust that I'm getting an expert level service in line with where I'm going, right? And so you may not see that as a risk. Maybe the provider doesn't see that as a risk, but it's a material risk. And I want to talk about documentation for a second. I was auditing some behavioral health notes last week, and the entire note was like a smart phrase. Like you're hovering over it, and the note, you see these phrases in documentation, and they say things like, the patient's condition is still severe and requires continued overnight management. We will continue the current medications at the same level. And these are phrases that are replicable phrases, but they don't tell me anything. AI is a little bit different. I looked at a note this morning, and this note said they used like an ambient AI listening tool, and anxiety and depression, the exact same to the word, like treatment plan. The only thing that was different was the word anxiety and the word depression. It was like, this medication is appropriate to treat anxiety. The patient will continue it and then it's just the same thing. And all of that is saying, like, look, these tools are only going to improve. I don't think those of us on this panel are going to get these tools to go away, but they don't change the requirement that like you manage your documentation, you review your documentation, and frankly, that you ensure that the license level that a provider of the service provider is appropriate. It's going back to as a documentation reviewer, as a non-clinical documentation reviewer, you can fool me. You can create documentation that represents that somebody performed the service who's maybe different from the person who did perform the service, but at some point you are holding that risk. Like you are holding the risk that you'll be investigated. You are holding the risk that the patient will say, well, wait a minute. Like I thought I was getting this service, but I never even saw the doctor. I mean, how many times do you talk to consumers who say, well, I never saw the doctor. The doctor was in the office for 3 minutes. And then you might look at the note and the doctor's like, I spent 40 minutes. So, this is important.
I'll give you one better than that. My youngest daughter tore the tendons and ligament in her ankle and fractured it. It's now been 4 months almost. When she scheduled to make her appointment at the orthopedic practice, she scheduled to see an orthopedic foot and ankle surgeon. When she got there, at the end of the visit, when she was looking at the business card of the provider, she didn't see it earlier. She actually was seeing a podiatrist. Now, nothing against podiatrists, nothing at all. But when somebody is making an appointment and it is confirmed that you are seeing a quote unquote orthopedic foot and ankle surgeon and you see a podiatrist, there is a significant concern that raises in my mind about the honesty of what's going on, because this was an orthopedic practice. And again, absolutely zero against podiatrists. Scott, Paul, we've worked with podiatrists all across the country who are outstanding physicians. That's not my point. My point goes back to the Deceptive Marketing Practice Act, which states if you are deceiving a consumer, you got a problem. I'm simplifying it. But Paul, let me come over to you for just a moment, because again, you know, this is something where I know you've looked at a ton of medical records, and these are things. Just this morning, I saw your response on making certain that when you're responding to these requests, these additional documentation requests from payers, that you're including specific information that highlights when something was performed, as opposed to just this daily progress note that may or may not be a complete and accurate representation of what's transpired.
Yeah. Well, my on this topic, my mind tends to be in behavioral health, because that was one of the areas where we have profound shortages of trained providers. And, understanding that, in the world of clinical training, there are no shortcuts. I mean, if you are a doctor, 10 years. If you are a master's level therapist, they're going to be, depending on what state you are, different levels of hours of supervision that you need to go through in order to be able to see patients on your own. A student, is still at zero, and they will remain at zero until they are a degreed individual. They can't perform any type of medical services. And this has been true of surgical students. It's been true of students in an academic setting. You cannot bill for their services because they are not credentialed. That's a big thing. It's like there has to be some type of credentialing here. If you've never, if you don't have an NPI number, you shouldn't be doing anything, and students don't. And I'm sympathetic to the fact that we have profound shortages in several medical specialties right now that are going to get worse in certain areas, depending on what those areas allow to be performed, and the different types of services that are required in certain states, depending on the type of epidemic levels they're dealing with different medical issues. But there really is no shortcut to clinical training. And if, I don't care how well the AI types that out. I just went through an audit with a behavioral health specialist in a state very close to mine where they just weren't including enough detail per the LCD for a TPE audit to pass. And it took a few rounds. It took a few different educators with a few different points of view, but finally we got to that point. And they understand supervision requirements. They understand what needs to go into every single note. You have to start with that understanding. And if you're not starting with that understanding, chances are students are seeing your patients, and that it's a lot harder to work backward than it is forward.
Yeah,
Terry, go ahead.
Yeah, on the documentation, and Paul brought up a good point. So did Scott. One of the things that we see too often is, and again, it's kind of an AI, but it's a manual AI that I think, or drop down macro, smart phrase,
Yeah.
whatever you want to call it. It seems like whatever software, whether it be Epic or NextGen or Athena, whatever you're using, they're putting in the E&M guideline language and not using that just for training and education. I mean, I'm seeing things like greater or less than 30 minutes. I'm like, no, 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 no. You need total time and what you did.
Yeah.
Or I'll see, well, this may or may not be this. And when I see that in behavioral health, it makes my head explode. Or I'll see, or. Well, is it and or is it or? I mean, especially in behavioral health. But we used to always tell providers, and we still do it on occasion, this is a legal document. It has to be able to pass muster should it be questioned in a court of law. But I even take it a step further. I'm like, with patients and being able to access their records so freely now, Do you really want a patient to see a record that says you may or may not have this, or it may or may not be applied to this, or, you and or could have this? They want to know that definitively you know what the heck you're talking about. And it makes me crazy because they're using the direction, and Sean, you and I talked about this in
Yeah.
one of our hashtag Terry Tuesdays a couple weeks ago, but they're using the phrasing of, education material in the AMA documentation guidelines instead of actually talking about the patient. It drives me insane.
100%. I lost where I was going to go with that, but
I have an example.
go
I
ahead.
wanted to
Maybe
throw in.
maybe it popped back into my
Okay.
head.
while you're spinning there. So I just wanted to remind everybody, and I say this all the time, that the EMR is a tool. Think about it in a different perspective. So I use QuickBooks to do most of my accounting, and it's wonderful because it knows that any restaurant that I put in goes under meals and entertainment, but it cannot distinguish when I go on vacation and spend something accidentally or when it is a true meal with a client. It all comes up the same. The other day, my husband started on QuickBooks, and he uses a distributor called United, and they distribute air conditioning parts. And QuickBooks went in and put everything in under travel because that's what it associated it with. So now when we send the reports off to our accountant, it just gives those categories. Think about the EMR the same way. You're using a macro statement for each and every one of these conditions. The patient may or may not present with, the patient does or does not have 50% or greater than, and none of that produces accurate descriptions. And just like the IRS is not going to take the excuse of, well, my QuickBooks did that, it wasn't me. The federal government isn't going to say you're Epic, you're eClinical, you're Athena, it was their fault, so you're okay. That's not going to fly either. And I think providers need to gain that confidence that they've got to make those changes, that relying on the EHR isn't going to cut the mustard.
100%. And you helped me to get the hamster back on the wheel. So now I remember what I was going to say. So dang hamsters. So, I have a lot of providers that will say to me, Sean, these medical records are for me. Okay. They may be your medical records, but they are ultimately owned by the patient. And when you say and or may or may not, and you're not speaking in, and I understand why sometimes providers want to be very careful not to speak in absolutes or definitives. I get it. But to say a patient may or may not have X when you have the laboratory results and you know exactly what they have, that's negligence.
Unspecified, Sean. Unspecified CKD, unspecified osteoarthritis, unspecified what?
Yeah. Yeah. Listen, and I get asked a lot of times, and Scott and Paul, they get CC'd on emails to where they share a client with me, where I get asked questions about, hey, I'm going to bill for an unspecified code. And sometimes it gets paid, and sometimes it doesn't. Can I just tell patients, so I don't have to deal with those times it doesn't, that I'm just going to charge them all cash for the same thing? No, it doesn't work that way. But anyways, listen, I think the bottom line comes down to this, and anybody correct me if you see it differently. Your documentation is key to being able to either halt a first level TPE audit or to quash an investigation by a unified program integrity contractor, or satisfy an audit from a MAC or a recovery audit contractor. And I want to say one last thing, and I'll give you guys the last word on this topic and we'll move on. Folks, please remember, when you get a notice from a unified program integrity contractor, a UPIC, it is not an audit. It is an investigation. And the request for documents is part of the investigation. That audit is a tiny piece of what that UPIC is investigating. All right. So let's leave that there. I want to jump to, and I think we can do this pretty quickly because I want to keep the whole team engaged in this. I want to jump to Medicaid. And I'm getting more and more clients reaching out to me saying the legislative requirements that are being imposed in different states, the amount of documentation, the cuts that we're seeing in the remuneration is making it nearly impossible for anyone to participate with Medicaid. But Paul, you brought this topic to the roundtable. So I want to give you the opportunity to talk about the dual fee schedules and to talk about the issues that you're seeing. And then we can kind of work through this one pretty quickly and then get into our last main topic of the day.
Well, uh, the main thing that we have an issue with as far as Medicaid, it's really not disenrolling people. It's just death by a thousand paper cuts. It's making the enrollment process of Medicaid more difficult. So, in theory, fewer people are on the Medicaid rolls. This is what we're looking at. Uh, it it affects it affects somehow some living in currently because my wife works as a fee for service master's level therapist, going to see people who are older on the who have psychological issues based mostly on aging, who have previous disabilities. It's still up in the air as to whether there's going to be Medicaid dollars for those people to still receive that care come 1/1/2026. As it applies to dual fee schedules, I mean, uh, usually if they Medicaid tends to be a secondary insurance unless you are in some type of long-term care facility, or if you're in some type of day treatment program for some qualifying disability, and that's going to be on the state level more than it is the federal level as how it defines disability. But with less money in the pot, that how we define disability may change on the state level.
I'm going to comment just a little bit
Yeah,
because we
go ahead,
got
please,
some new
Terry.
information over the weekend. Um, One of the things with Medicaid is that Dr. Oz came out and talked about it too. They are adding $200 billion to Medicaid, so that was something they said that's supposed to be there. Now we don't know what capacity, we don't know what programs, but that is the plan. Also, because they did find 2.8 million um, people that were on Medicaid that were in two different states, and you're only allowed to be covered in one state, that's going to save billions of dollars. I think they said a total of 18 billion per year by making sure those are cleaned up. Now, in saying that, I do see that there are going to be some inadvertent people that are going to be pulled off those eligibility lists because of whatever reason. That's going to, there's going to be some minutia there. There's no question. Hopefully, and I know if there's going to be pain points here with the cleaning up of the Medicaid issues that we've had over the last several years. Hopefully, yes, that will now make sure that it's for people actually entitled to the program. I'm not fooling myself. I know there's going to be some rural hospitals or some areas that are definitely going to hurt with some of the restrictions now that are being put on. But again, in saying that, look at both sides of the coin too, that it has to be done. There's always pain points when you're cleaning up a mess. How many times do we do, and I'll just go back to all of our auditing, where we find that, a provider is billing for something they shouldn't be. And they're like, yeah, but I don't want to stop doing that because it makes me money. And it's like, yeah, but you're not entitled to that. So, one of the things on the fee schedule that's being taken away for 2026 or proposed taken away is the social determinant of health code, the what is it, G0136, and it's worth $18. Well, it's not a screening, and doctors are using it as a screening. And so it's an assessment when they felt that there was something that patient, there's a reason to believe that the patient couldn't either get their treatment or it was interfering with their treatment, or there was something where the social determinant of health was impeding their ability to be able to get what they need. And that wasn't being done appropriately according to the documentation. So they're like, well, we're going to do away with it. Kind of like, remember consults? They got rid of those in 2010 because consults weren't being reported appropriately. So just kind of looking at the big picture, I'm pleased and happy that they're finally cleaning it up, but I'm in a little bit of distress here because I do understand that there's going to be people that really need their Medicaid and are entitled to it. They, based on the guidelines that, it's for people that need it, that may drop off. And I definitely empathize with that situation. Unfortunately, there are some pain points when you clean up a mess.
Yeah,
And I don't know how else to put that. I'm not,
no,
I'm trying to be
and that's
sensitive to it.
that's a fair point. And Paul, I'll get right to you. I think the most important thing from my perspective is that every single administration, regardless of what side of the aisle you are on, every one of them has continued to kick the Medicaid issues, which have been festering for decades, down the road, ignoring glaring issues, ignoring the things that people who have been monitoring the situation for years and decades have been, and I've been one of those who's been very vocal about it. I was very vocal. I've written major pieces about what's transpiring with the Medicaid cuts at this point, the $1.2 trillion worth of cuts. I agree with you, Terry. There are going to be, unfortunately, some people that become victims of the cleanup who don't deserve to be penalized or punished because they truly are in a category of individual that needs this entitlement program. But it's both sides of the aisles for decades that have kicked this can down the road too far. And that's why we're at the point where we're at right now, where you almost have insolvent situations in many states. And you have several governors, you have mayors of certain cities that are fighting back and saying, we're going to continue to do what we want to do, when we do it, how we do it, why we do it, and we don't care. But they don't realize that standing on a podium screaming and kicking like a petulant child isn't going to preserve the system. It's going to continue to add more problems to it, to the point where it becomes bankrupt and they shut it completely down. And that's what's scary. Paul, go ahead. I'm so sorry. I didn't mean to cut you off.
No. I think a little bit in this realm about Medicaid managed care. When I was a director of coding and regulatory compliance for a hospital that had 2/3 population Medicaid insurance, Medicaid managed care plans shifted with the wind based on who their insureds were. Medicaid managed care plans went broke because they were poorly managed, or they were small and they attached themselves to one facility, and they had big ideas in their head, but those big ideas quickly became the stuff of nightmares, and they went under. And then suddenly they're reconstituted under another name with the same people running those Medicaid managed care plans. So it's something of a treadmill. And when you get to that situation, and there are a lot of states out there who have gone to Medicaid managed care 100% of their plans. They've just offloaded it onto private enterprise. Well, now the day of reckoning for that is coming to play. In the same way that we're seeing a day of reckoning slowly come out for Medicare Advantage plans, who are now, there's a lot of dark money that went into killing legislation within this bill to scale back Medicare Advantage plans. Whenever we privatize things like this out, I mean, I'm all for controls. I'm all for, payment controls, but understand that, when a patient's needs change with the wind, so does their coverage when you have a private industry, fronting themselves under a government plan.
Yeah,
and it's not going to be pretty.
Yeah, that's such a good point. And I'll give Stephanie and Scott and Christine an opportunity if you want to have a final word on this, but you're right. And my biggest concern is that people are ignoring what's transpired in Medicaid being shifted to Medicaid Advantage through the privatized programs, thinking that the same thing could not happen to Medicare. Folks, if they shift Medicare Part B by 2030 or 2032, whatever it is that they've been talking about, this will be the worst possible situation for our seniors and for some of us who are getting closer to being eligible for those benefits. Yeah, I get you. So again, I'm not trying to politicize anything. I'm giving actual known, and the good ladies and gentlemen that are on this podcast with me know the extent to which I'm tied into a lot of folks on Capitol Hill, at CMS, within the administration. I am constantly pushing back on the fact that people want to shift Medicare Part B to private insurance companies. Folks, you will go to prior authorizations for everything. You will see a higher rate of denial. You will see a longer wait period for people to be able to get their treatments. This is not good for anyone. All right. With that said, let me pause there. Let me give Stephanie, Scott, Christine, if any of you want to join in that conversation, I'll give you that. Otherwise, we can shift to our last conversation.
I was just going to say Medicare Advantage is the program where you get like a free gym membership, but you can't get your knee fixed. That's kind of the way what it's evolved to. Look,
This is gym membership, by the way.
what I would say about Medicaid, and this just sort of concerns me as a practical matter working in the field. I think, there are obviously clinics in some areas that are designed largely to have access for people with Medicaid, but a lot of like our clients, the people who I might work with, a lot of medical practices, they will accept Medicaid at some level, but it's not something that's particularly profitable for them. And, a concern I have that we'll just have to see play out. So when all these discussions came around and the political point was, well, if you're in the basement playing video games or whatever, you probably don't need Medicaid. At the visit note level, like when I go and I actually look at the notes of people that are on Medicaid, those people I don't see a lot. Like I don't see a high service utilization from those people. I see a high service utilization from like pregnant ladies, and my understanding is also a lot of it is nursing homes for like older people. My concern, cycling back to where I was going with this, was when we place all these requirements, and again, we'll just have to see how they play out. But if there's a requirement potentially that you are looking for work or you're working X number of hours a week, and you have to constantly tap back in with the state to make sure that your eligibility markers are being met, one of our biggest problems on the practice side at a base level is eligibility verification and making sure that the person is entitled to the benefits at the point of service. And because Medicaid tends to not pay very much, my concern as these changes unfold, and frankly, as a consultant, I can't argue the point, is that the practice just at some point says it's just not worth it to us for the money that we get paid to constantly have people getting kicked off of the program, or the state screwed up the paperwork and they didn't get the thing where the person filled out that they tried to work 20 hours a week, or whatever those manifestations ultimately are. And so the access becomes harder even for people who are entitled to the program. And, again, if you want to make it like a government cost issue, they just end up in the emergency room at some point and the cost is ridiculous, right? And so,
100%.
I think I would agree with everybody who would say that Medicaid requires some cleanup, that Medicaid could be run more efficiently, that societally, if we're going to have this program, we want to allocate the resources to the people who are in the most need and challenge people who don't need it or who could find alternate mechanisms to do it. As a pragmatist, those are concerns that I have, right? Like, one, is this actually going to save us money? Two, is it going to result in a world where if I'm running a practice and in theory I would like to have a certain amount of Medicaid business, helps the community or does whatever, but I'm constantly on the phone doing verifications or these claims are getting denied because they had coverage this week and they don't have coverage that week. At some point I would just be like, I can't do this, right?
Well, let's shift to our last topic because that has to do a lot with saving money. Go ahead, Christine.
Before we shift, I
Yeah.
had a couple of thoughts. So, you know, Medicaid, I've got a lot of mixed feelings about it. I've known people, unfortunately, that have been groomed or lived generationally to just rely on Medicaid, and that is a huge problem. I also think that there are other things out there that we haven't put enough effort into. The CHIPS program. I was talking to a young mother over the weekend who had no idea what the CHIPS program was for her children and was devastated that her kids were going to lose their Medicaid. No child should be uninsured. We've had the CHIPS program since '96. It's not more than 5% of your overall income, and it's an underutilized product. The second thing is the marketplace. I like the marketplace. However, even as a seasoned person with knowledge of healthcare, the marketplace does not, in my experience, always put forth the best products forward for people. And they're still frustrated because they see that. I used to do that too, Paul. Paul said when he hears Chips, he immediately thinks of Eric Estrada. And that I was a diehard Chips fan. But yeah, let me bounce back to the marketplace. The marketplace does not always have that really clear perspective. And suddenly you're looking at either $0 or something that is, way eccentric, $1,400 a month. And people say, well, I just can't afford that. It's not knowing how to find those in between plans or how to go and look at what your specific needs are. And even as a seasoned person, that's a good week-long project for me every year, is trying to find the best bang for the buck. So maybe instead of focusing on taking away so much, maybe we need more education. We need education on programs that are out there, education on how to navigate the marketplace better. Yes, we are going to revamp Medicaid. It's been abused in certain areas for such a very long time, but people need to know what the alternatives are. If not, it looks like a punishment rather than a redirection.
No, that's great. I'm with you. I agree with you 100%. I think we're all on the same page. The program is vital for a segment of the population that desperately needs it. But for others who have been groomed to take advantage of it, it's enough already. All right, let's move on because we could continue this conversation for hours. Let's talk about something that CMS is desperately seeking to implement through their proposed rule that's going to cut out about 90% of the cost, and that's for skin substitutes. Now, I'm not talking about collagen bandages. That is a different conversation for a different day. I'm talking about skin substitutes, where these are right now categorized under biologics. And the proposal is to remove them from the list of biologics and to place them under the incident to billing provision, which means they're now bundled into an office visit because they are an integral yet incidental part of the overall service. So I'm going to pause there. I'm going to let Stephanie start this one because Stephanie, you're really the one who got my juices flowing with this conversation about a week ago, and you got me writing a blog about it. And then we talked a little bit about it. I think Andrew Feldman, an attorney that you and I both know very well, his comment last week was, "I'm just waiting for the hammer to drop." So let you guys take this one on because I know Stephanie, Christine, Scott, and Paul, you guys have extensive engagement with this.
Yeah. So, this is an area that I am just really frustrated with based on the defense work we've had to do up to this point already surrounding these types of supplements or, substitutes, whatever you want to call them. And the reason I'm so frustrated is because I'm constantly hearing in the industry from our physicians, for example, who are out there taking care of very complex wounds. And, for example, this year I've been working with vascular surgeons, and they're going in, the patients are not healing, they're trying different things because, certain devices or whatever they're using, biologics, take them to a certain point and then it stops working. And the question is, and I think their frustrations are valid, where they're saying, okay, what am I supposed to do? Walk away from this patient and leave them with, a hole the size of my fist because I had to try this other product? So, from that standpoint of patient care, it's extremely frustrating just learning more from the physicians I've been working with. But one of the things I've noticed, and we've talked about this before, I do not like politics. I do everything I can to stay the heck away from them. Um, some of my friends on here like it, so they fill me in when I need it. Yeah, Terry, Terry Scott, or Sean for sure. But the thing that's driving me insane, well, Sean, whether you like it or not, you're in the middle of it.
I get dragged into it.
But it's really frustrating to continue to see these updates coming out from CMS that keep, pointing to the fact that their solution for something is going to be on the back of the providers. Why does this have to be incident to the provider service? Why are we not looking at the cost of all of these things? Why are we not looking at the distributors, the vendors, the manufacturers, the people out there who, I think I've talked about this before, but I met someone who, thank God, I barely know and we did not enter into any kind of contract with, who's sitting there bragging about the millions he makes every month being a middleman for these substitutes. So it's like, where the heck, and no, Sean, that one wasn't with you. I covered my ears and ran, and I'm like, thank God, I don't want anything to do with this guy. But, where is the accountability for these other people? And, Matt Lawhon commented on another post this weekend, Sean, about how, yes, there can be accountability for vendors and distributors. But the thing is they're purposefully not putting things in writing. They're just saying things verbally. They're trying to get our physicians and practitioners to use their substitutes for other purposes as well. So it's not even like this is just a skin substitute issue. I'm seeing it being used in spine. And luckily, I went back after the weekend in the comments on the LinkedIn post. Thank goodness the people that I had conversations with, their billing company caught it for them. So they didn't
Very
actually
fortunate.
bill, even though their spine surgeons are starting to use these for like the dura preventatively, not even something where there's a repair needed. So there's just so many issues here, and I'm extremely frustrated that the CMS updates are pointing to the providers as that solution.
Well, one of the things that I want to go back to and unpack just a little bit was the culpability and liability for distributors
Mhm.
because they have to be held accountable. Paul and Scott work with me incessantly on the compliance for our large orthopedic and rheumatological practices. One of the things that I came up with these guys and Stephanie, even with your help a while back, we came up with what's referred to as the vendor validation program. This is something that we have worked on extremely hard to make certain that we are, before one of our clients engages with a vendor, that they provide us all of their marketing material, all of their information with respect to the coding guidance that they're providing, everything related to FDA claims that they're making, whether it's FDA cleared, FDA approved. We are now finding, I just did a big one for one of our groups, where now what I'm starting to see is the distributors are not even mentioning FDA clearance or FDA approval because they don't want to deal with it anymore and they're leaving it out. So now one of my biggest comments on my analysis is, hey, they're silent on FDA, whether it's approved or cleared. My recommendation is to cease going forward with this organization or this group until we have a definitive understanding for how they are viewed by the FDA, whether it's pre-marketing emergence under Part 361 or whether it's not under Part 351. And again, we're starting to see a big resurgence in a lot of these amniotic coverings. And again, these Q codes, folks, all of these Q codes, before you put them into your billing systems, I'm not telling you not to bill them. What I'm telling you is before you put them into your billing systems, evaluate them. Have them independently verified that what they're telling you is factual, it's compliant, and it is the way you're supposed to do things. Because the worst thing that you could run into is a situation like a lot of folks ran into with the amniotic fluid injections, where some of them have gone bankrupt, some of them have suffered massive clawbacks to where it crippled the organization for a period of time. But this is something that you got to be careful of. So let me go to Christine, and then Scott, I want to come to you because I know you both have done a lot with the skin substitutes as well. And then Paul, I'll give you the last word, my friend.
Well, a couple of things. Vendors have always had that way of coming in and giving us a great view of this is the biggest money making thing that you're leaving on the table. Unfortunately, the six of us have on a daily basis, we have to go backwards and help these providers mitigate the damage that was done because there were certain things, like you said, Sean, that were just not included in that guidance. The guidance is always favorable as to why you should do it and very rarely include the risks of why you should do it. And I'm very sad that certain providers who don't have a compliance program and they don't understand that research needs to be done. I had a case, a couple of months ago that I was working on. They invested $100,000 in a lab to find out that the services that they were producing are not reimbursable. And so, and it was a hard thing to do because they'd been paid and they had to return the money back because it just was not. So that's a big thing. We have been dealing with these vendors for a very long time. I'm not saying all vendors are inappropriate, but it is important that every practice does their due diligence, look between the lines, and implement the policies so that everybody in the organization knows how we're supposed to follow them.
Scott, I know you've been dealing with this with some of our orthopedic groups, so come on.
I'm an old soul, so I used to watch the Honeymooners. I still do sometimes. This goes back to the 1950s, and Ralph had all the get-rich-quick schemes, like the mystery appetizer that turned out to be dog food, and the point of that is that, and just to build on Christine's point, there are no easy get-rich-quick schemes in our world, and to pick up on what Stephanie said a little bit, I agree that it's unfair in some respects that it's falling on the backs of the providers in some ways, but the providers are the ones that the program pays. And so when you think about that relationship from that perspective, the agency, CMS, is expecting, for better or worse, that you know the rules of the program and that you bill according to the rules of the program. Now, to Sean's point, we've worked with a lot of these skin substitute programs and the collagen dressing programs, and these vendors are in some cases playing, in my view, fast and loose with coverage policies. We worked with one who basically said, if you're starting the patient on home health, have a 1 day in the middle so you can order all your dressings and have them paid under Part B, and then put the patient into home health. But once they're in home health, they're not covered. And when asked about it, said, well, that's how we show compliance, right? We make sure they're not in. And so you, as a medical provider, for any service that you're providing of any material volume or value, need to understand what the coverage conditions are, what the terms of the coverage are, and then take a step back and put on your skeptic's hat and say, well, they're telling me that I can do this for this entire patient population, and they're going to help me, and it's, we're all just going to make a lot of money on this. And just ask yourself clinically, how you feel about that. Like, do you feel that same comfort or confidence level? Because a lot of this, this is happening because they're being overutilized and they're being overbilled for in the eyes of the program, I'm sure, and they just keep getting more and more expensive. And, we've seen artifices. I mean, if you're paying for something under an ASP plus 6 program, we see things out in space where there's, rebates coming in on the back end that may not be being accurately represented in the price. And so it all feeds into this notion that this is just a runaway freight train of money, and look, the government, for better or for worse, as a taxpayer, I will say for worse, tends to take longer than we would like to discover that it's massively overpaying for something. But unfortunately for you as a provider, when that discovery happens, if you're on the receiving end of a lot of this money, it may be time to like get the virtual checkbook out, right? And so, I think all of that is to say you should have a high degree of skepticism when you're going into this. To finish my point where I started, for those of you who don't watch The Honeymooners, Ralph Cramden had this great appetizer and he fed it to his boss and his boss loved it, and then somebody disclosed that they recognized the smell because it was dog food, right? So there's a lot of dog food in our universe when you go through these vendor products, and you need to make sure that you're doing your due diligence.
Excellent. Paul,
Okay.
round it out.
I have two pieces, one piece of severe scolding to bring out. Medicare is the one who handles the HCPCS program. They're the ones who create codes. They're the ones who create codes and the ones that just say, oh, well, this applies to this graft. Just because a code is created doesn't mean it's something that's automatically billed. And honestly, Medicare's due diligence when creating codes needs to get a heck of a lot better. Don't just leave a code set out there. Oh, it's a quarterly update. Here's a new skin substitute code, to use as you wish. Well, that's not the way that works. And to make another 50s TV reference, since we're rounding that out, I would like to go back to You Bet Your Life. If I had a duck that was above me with today's secret word, the secret word that he would be holding is the word scheme. Whenever you see indictments, and Sean, we've seen plenty, whenever they start doing things that deal with fraud and abuse, they use the word scheme. The example that Scott gave, well, you just skip a day in order to supplies again. That is a scheme. That is something that is very easily apparent to an investigator with even the fewest amount of IQ points. And Sean and I have seen a few of those. But if it looks like a scheme and sounds like a scheme, then the duck is going to drop from the ceiling. And yes, it's a scheme. Don't do it.
Absolutely. All right. What a great panel discussion that we've had today. I know we've been gone for a while. My hope is that with everybody's travel schedules and everybody's trial schedules and work schedules, we can get back on track. My hope is that we'll be back in 2 weeks, but I know Terry and I will definitely be here tomorrow for our hashtag Terry Tuesday. So thank you all so much for tuning in, logging on, and hanging out with us just for a little while. And remember, until the next time, be good to yourself, but more importantly, y'all be good to each other. Take care.